Hi everyone, welcome to GoggleDocs' first video podcast. So who are GoggleDocs? Well, four doctors based in the UK. We all either work in the field of diabetes or have an interest in diabetes. And the whole point of these podcasts is to have an opportunity to have a really informed, quite a chilled conversation about the cardio-renal-metabolic areas of medicine and beyond as well. So we're looking forward to having quite a good chat. We're all mates at the moment, and I hope we continue to be. And we look forward to you all joining us during these discussions. So I'm going to go around the others, and we're all going to introduce ourselves. So over to you first, Kevin.
Thanks, Amrit. Hi, everybody. Kevin Fernando. I'm a GP partner in North Berwick Health Centre, which is a practice east of Edinburgh. Long-standing doctor there. I've been nearly 12 years as a partner there, and a long-standing interest in diabetes and medical education. I'm also currently Education Director of GP Notebook Education and also Scottish lead of the Primary Care Diabetes Society. So thanks for joining us, everyone.
Hi, my name's Amar Patana. I'm a consultant diabetologist in the West Midlands. Have a massive interest in data, diabetes, and geeking out, which I share with my colleagues and friends here. And yeah, looking forward to get into things with GoggleDocs.
Hi, I'm Patrick Holmes. I'm the old man of the team. So I'm a GP partner in St George's Medical Practice, which is in Darlington in the north of England. Also a CCG diabetes clinical lead for Tees Valley, and work at my local foundation trust as a GP with a special interest in diabetes. I also geek out on the data a bit like Amar. Amrit?
Thanks, Patrick. So yeah, I'm Amrit. I'm a GP based in North London. I too have an interest in diabetes. I suppose I'm the least geekiest of all of the members of GoggleDocs. So I'm mainly here for the banter, to be honest, which will be great, I'm sure. But let's get going. And Amar, I'm going to get you to kick off. Talk about guidelines and license changes that have taken place over the last 12 months.
Yeah, no, thanks, Amrit. We've had a lot of changes in the last year, to be honest, not just guidelines, but medications and medicines themselves. They've had a lot of different changes to what we can do with them and what we can prescribe them for. Going straight into the medications, I think first is really, we've had changes to the license for a couple of SGLT2 inhibitors, so canagliflozin, dapagliflozin. Canagliflozin is licensed now in renal disease, with 100 milligram dose licensed up to a dialysis even, but you can only initiate it after a kidney function of, what was it, over 30, isn't it? And dapagliflozin is now licensed in heart failure, not just in type 2 diabetes, in heart failure. And again, that license is also, well, we can talk about that actually, can't we? It's not quite clear exactly all the way down.
Somewhat controversial, in my opinion, wasn't it? Well, we had clear guidance for canagliflozin and follows the evidence. Of course, Credence, the seminal Credence trial clearly demonstrated benefits of canagliflozin in reducing progression of kidney disease. And in Credence, they did recruit down to an eGFR of 30, didn't they? Whereas the DAPA-HF trial, the heart failure trial, looking at the compelling benefits of dapagliflozin for heart failure, also recruited down to 30. But it appears that dapagliflozin has been given a license with no lower cutoff for eGFR. Certainly, that was my understanding. Is that what you took away from it as well?
Yeah, I suppose the local feel for us is that there's not a great deal of clinical experience in the lower eGFR, so going down towards end-stage kidney disease. So yeah, a little bit of confusion. But the other thing I would say is that we're starting to get into the realms where there are very few patients potentially on our registers who are going to be eligible. And that's something that I always think about. I mean, how many patients are we going to be having on our lists who might be eligible? That's just me being a little bit of a cynic, but also something that potentially makes it quite a targeted approach as well. If we can identify those patients, we could really make a difference if we had clarity.
And I mean, most of the people who have a kidney function at GFR less than 30, you'd expect them to have some kind of specialist input at some point, or have different considerations. So again, that's not preventing you from starting. It's just kind of maybe at that point there'll be a more specialist input, which may consider it and consider the options as well. So it gives the option there.
Yeah, and I suppose it also, I mean, in primary care, we do have a fair number of people with an eGFR above 30, but often they're their age is above 90. So, they're probably not going to be prime candidates for these agents because you're dealing with multimorbidity and frailty, where there's clearly that wasn't the cohort of patients recruited in the seminal DAPA-HF study, which informed that license change.
What do you think this does for the clarity of the class of SGLT2 inhibitors?
Well, that's what I was going to just
because does it just muddy the waters even more for your generalist in particular? What are your thoughts?
Absolutely. I mean, are we prescribing it for glycemic control, reducing the progression of kidney disease or heart failure? I mean, I'm not arguing some really compelling results, isn't it? DAPA-HF, a number needed to treat about 20. Credence, also number needed to treat in its 20s as well. But you're right, to the non-specialists, to the non-geeks like ourselves, sadly, it is very confusing. And, every day I'm asked by colleagues, is this patient appropriate for an SGLT2 inhibitor? And it really depends on why we're prescribing it, isn't it? Now that we're into the realms of prescribing SGLT2s out with the context of type 2 diabetes, absolutely, Amber, I agree with you. I think it does muddy the waters, and more than ever, education is required, from groups like us, of course, but also from our colleagues in the pharma industry as well, to guide the correct and, more importantly, safe use of SGLT2 inhibitors.
I think that's what you said.
Ironic that this was a drug which was initially developed to improve glycemia by urinary excretion of glucose, and now the people who seem to benefit most from it, you could argue, are the ones with poor renal function, because there's a strong association with heart failure, and so the people who benefit most are often the ones we couldn't initially prescribe to, and even now there's only selected agents we can prescribe based on the evidence. So it is, I would agree with you, it is a challenge for generalists, because they're still sort of catching up with these agents, and to be given new evidence which would suggest actually, the people who benefit most from this are the ones who have got poor renal function, and where there's still this perception that perhaps the reason why SGLT2 inhibitors were not indicated with lower EGFRs is that, are they dangerous in those patients with poor renal function, which we know is not the case, but I think out there, it is confusing if you've been told one story and then the story changes.
I think that's interesting, because I think these guideline changes now have kind of heralded, we've always thought it, but now they've heralded the switch of these medications being diabetes or type 2 diabetes medications to now renal, cardiovascular, looking at that side, and everyone's going to be fighting for it. And that's kind of mirrored in these guidelines that have come out really over the last year, and probably will come out in the next year as well, that they're slowly adapting to say perhaps now we're looking more at less about glycemia and saying, well, that's still a major input, but less about glycemia and perhaps looking at other possibilities. So we have the PCDE guidelines, we've got the KDIGO guidelines, or KDIGO, depending on how you say it, and also the American, the ADA-ESD joint guidelines. All of them are changing now from glycemia to incorporate all that. What were your thoughts really on kind of these guidelines and the changes?
It's a real shift in thinking for many clinicians. And I think if I didn't have an interest in diabetes, I perhaps might be caught off guard by that, because it really is. I mean, I think, if you have perhaps a bit of an understanding of the trials that have led to those changes, then fair enough. But if you're not up to date with those, it can be quite a massive change. But yeah, certainly something that needs a lot of local attention, I think. And there's a real role for local education to kind of look at a lot of these licenses and these guidelines where we're treating uncontrolled type 2 diabetes. What does that now mean? Yes. And as you said, it's not just about glucose, but that uncontrolled type 2 diabetes label can be cardiovascular, can be renal, can be metabolic in terms of glucose. And so yeah, it's a new world, but exciting, because we have data that backs it up and products that back it up now as well.
The challenge though, Amma, isn't it? And I know you've heard me say this before, in primary care, we get approximately over 200 plus guidelines a year, excuse me, across all disease areas. So that's 5 a week. So, and a lot of those are, as you've said already, as Amrit said, within the sphere of CRM, cardio-renal-metabolic. So it's really confusing for us in primary care. There's rapidly changing landscape, guidance, as you said, license changes that we briefly talked about, as well as new products as well. So incredibly challenging time. Don't get me wrong, it's absolutely right for the patient. We have some fantastic therapeutic options that not just lower sugar, but translate into improved cardio-renal metabolic outcomes now, improving both quality and quantity of life. So it's a great time for us to have all these therapeutic options. But as you said, a very challenging time as well. Given
they're now backed up by guidelines as well, aren't they?
Yeah, absolutely.
For NICE, just hype on that.
In fact, what's your take on that, Patrick? NICE, the one guideline we haven't seen is the NICE guideline for obvious reasons. But even before the pandemic, NICE a bit slow off the mark, weren't they, to incorporate some of this new practice-changing data?
Absolutely, they've been slow. Although you could always, it depends. In NICE's defense, they did write to us a couple of years ago now and did say that, in their guidelines, well, first of all, as with all NICE guidance, it's guidelines, not tramlines. And I think that when we talk about guidelines, that's to guide clinicians. We're in the middle, as we're talking, we're in the middle of a pandemic. That's part of the reason we're all meeting in this format. But the so do guidelines apply in that case, or you do need to use your clinical nous and when you're managing patients. But when going back to NICE, they did write to us and say they did say you need to be looking at the comorbidities. But what we haven't got is that spelt out in black and white what that means to your everyday GP, or for that matter your everyday diabetologist, about how we recommend what treatments. And I think all of this reminds me a little bit, there's always been this worship of surrogates. I'm old enough to be taught by a consultant before UK PDS. So, that's back in the dim, distant past. And he said, don't just treat surrogates. Don't just treat glucose. I think, remember, in UK PDS, we didn't know glucose for type 2 diabetes actually made a blind bit of difference before then. So we should be led by hard outcomes. And I think, and that's what all this evidence, particularly in terms of diabetes, it's not just about lowering glucose. Some of these agents do more than lowering glucose. They prevent people from developing renal failure or heart failure, or going into hospital with heart failure admissions, or perhaps even avoiding heart attacks and strokes. So it's exactly the stuff we should be doing. And it's you can't shout loud enough about the importance of some of these neuro agents in terms of really preserving people's health and letting them live more quality life going forward. So so we all need to listen up, guys. Whoever's listening to this, this is important stuff. This will help you manage your patients better, and make them perhaps have those birthdays or see their grandchildren, etc. So it's important stuff.
So just before we move on,
I was going to say Patrick's putting the nail in the coffin for metformin now, isn't he? But I'm not going to go there.
So before we move on, because the next thing we were thinking of talking about, guys, wasn't it? Were some of the more recent trials over the last year. But was there anything else, Amar, just like any other bits and pieces that came from guidelines or license changes? I know GLP-1s, some in terms of dulaglutide. There's a bit of an update there.
Yep. So, we use 0.75 and 1.5 milligrams once weekly for dulaglutide. That's now, but last month, was it or so, got a license change to allow for the 3 milligram and 4.5 milligram dose, which is great when you look at it, because the main reason it's great is because they've kept the price the same.
Yeah.
So whether you go 1.53 or 4.5, it's the same cost in the NHS at least, and you got beneficial effect on HbA1c and weight, especially in the 4.5 milligram dose. So it's another armament, so another addition to our quiver, to another arrow to our
string to our bow.
String to our bow. There we go. I was trying to think quiver, armament, arrow, bow. There you go.
And the Ward 11 data, wasn't it? Which interesting. In terms of GLP-1s, I use a number. Well, I suppose I just use 2 GLP-1s these days, to be honest. Dulaglutide and semaglutide, both the oral and injectable versions. We can talk about the oral version. And as it stands head to head at the standard doses, I think injectable sema pipped dula, didn't it, in terms of potency, HbA1c and weight reduction. But certainly now that we have these higher doses, especially the 4.5 milligram dose of dula, does appear to be at least equivalent anyway to injectable sema. So actually, that caused a bit of debate locally, because there's no doubt, and I'm sure you all agree, that the doula device is much easier to use and initiate. Especially, I've started it on occasion virtually as well over this last 9 months. So again, it's all about individualization. They're both good molecules, aren't they? They're both good GLP-1s. And depending on that person sat in front of us or appearing virtually in front of us, I might consider those higher doses of doula, or might go with injectable Ozempic injectable sema. So interesting times, isn't it?
And of course, the beauty, just going back to those hard outcomes, we know you get those at the starting dose of Lilly's Trulicity, gelaglutide, 1.5 at least, which is the standard dose, whereas there is that titration which you do require in Ozempic. I'm a great fan of that. I think there's some fantastic results from the Ozempic trials, but you do need a little bit more input in terms of titrating and there's, and as you say, in these extraordinary times, that can be a little bit more challenging for people. If you're like me, your general go-to class of agents when you're thinking about injectable is GLP-1.
So overall, there's still very low initiation, isn't there, of GLP-1 as a class, UK wide. Whereas SGLT2s are really flying now, aren't they, over the last few years?
You could argue that's part of the reason why, isn't it? SGLT2s have taken that bit.
Yeah, it's interesting because I think obviously we can consider these new products or license changes almost as new technology in a way, but it's the implementation really that I think perhaps hasn't had as much kind of research and enough of a spotlight put on it, because ultimately that's what we need, isn't it? Having this great data is brilliant, but if it's not actually resulting in real world outcomes, then
Patrick, Q Sam Saidu there, isn't it? You're always quoting Sam.
Absolutely. Well, the quote is, these drugs only work if A, healthcare professionals prescribe them, and B, patients take them. And I think, I think that should guide any right-minded clinician, particularly when you're developing guidelines, which I'm sure we've all been involved, in our local guidelines or regional guidelines. And it's, trying to get these agents out there and used, because it's not just low initiation when it comes to GLP-1, persistence is low. But, so it's a lot of people fall at the first hurdle of GI side effects.
Okay. Shall we move on to some of the trials over the last year? I know there have been a whole host of SGLT2 inhibitor trials. Anyone want to take us through some of those?
I'll start with I was going to start with the Virtus if you want.
Yeah.
The reason I want to start with that really is it's because we've been spoiled for choice, haven't we? We've been spoiled with these SGLT2 inhibitor trials. They've been telling us, they're amazing, the revolution in type 2 diabetes care. And then Virtus came along and it got everyone talking about, actually, let's put the brakes a little bit. Let's see what's going on here. And it's interesting. We're seeing a similar thing in these vaccine trials now. We've got great data for some, and then one that's not as good as the other relatively, but it's still a great trial. Same thing with Virtus. It was not as good as the others. It didn't show that cardiovascular superiority, cardiovascular benefits, besides hospitalization for heart failure. But in terms of a glucose lowering medication, a diabetes medication, it worked pretty well. So we had this big fight saying oh, look, it's not as good as these, we can't use it ever again. And then we have people saying, well, actually, look at what it does and the cost and the benefits. And I found that really interesting. I really like that trial for that.
I think I'll have a celebratory drink the day that a patient comes to me saying, I want this SGLT2 inhibitor over another one. I think that would, then I'd be like, this is brilliant. Patient awareness is definitely going up. If only we had as much awareness in diabetes as we do about COVID vaccines in the general public, that would be amazing.
It's all apples and pears again, though, Amrit, isn't it?
Yeah, absolutely.
All our time as self-professed experts in the field of primary care of diabetes, telling you can't compare these trials. And what we're doing now, we're comparing these trials.
Yeah, absolutely.
So, because different, we all know, don't we? Different trial designs, different participants. But I suppose we're just trying to generalize some of these results. But we do need to be very aware that these are ultimately all very different trials, aren't they? And we shouldn't, you're right, Emma, it was a foregone conclusion, wasn't it, from everyone that Virtus CV was going to mirror all the compelling results of EMPA-REG, of Canvas, etc. And the headlines everywhere, disappointing result. It wasn't a disappointing result, was it? But negative. I suppose this is publication bias, isn't it? So yeah, interesting time. So, but yeah, for me, I thought it was still good for the class because it did, mirror some of those benefits. Albeit you can talk about the statistical significance, of course, but that hospitalization in heart failure, that was broadly consistent, wasn't it, with what was observed with the other trials. So that was very reassuring. And the kidney benefits were, again, maybe another day we can debate the finities of that, but again, broadly consistent as well too. So I think there was a lot to take away from that trial. In that SGLT2s, to me, are still the compelling choice after metformin for most people with type 2 diabetes. But as Amal alluded to, even before metformin, I know, and I do.
Or at least at the same time as
OECD guidelines.
Do you think it's time to say goodbye to metformin, Patrick? No,
because it's generally well-tolerated medicine. But I quite like, as Amar's indicated, there are some guidelines which would now perhaps indicate we start with two agents, metformin for its glucose lowering and its sort of legacy. It's a comfortable agent we're used to, which seems to be safe, no hypos, etc. And then, with the SGLT2 inhibitors, well tolerated generally. And in fact, actually, some of the side effects are related to the level of the glucose. So if we can get that down with another agent such as metformin, then you get the best of both worlds, really. So I think, and other guidelines have been suggesting with poorly controlled blood pressure, we should go in with two agents. We've had that now in terms of the ADA ESD position statement for some time, saying two agents. And I think now we're getting hard outcomes with SGLT2 inhibitors. Yeah, why not? Just give it from the get-go. And these agents may be a little bit pricey at the moment, but they're going to be generic in the not too distant future. So and I bet you $1 that every $1 I've got, as soon as they become generic, the guidelines will change. I'm an old man who remembers how suddenly simvastatin was the statin of choice, and as soon as there's atorvastatins available at the same price, we change our guidelines. So yeah.
Do any of you initiate? Have any of you gone down that path of initial dual combination therapy?
Quick one too.
Not yet.
I have, but the only faff is, of course, the dose of metformin. So you've got that titration, which is a little bit clunky. I would love it to, somehow for a very well tolerated dose of. I have, for what it's worth, I've started people on the 850 fixed dose combination of SGLT2 inhibitor and metformin, and I've done that successfully. So take one tablet, for I say 4 weeks, and then after 4 weeks they take one twice a day. So I've done that.
We've seen that a lot in the private sector locally, actually.
But
again, that comes back to the argument about cost.
Yeah.
I've done the quick one too, where 1 month metformin, then after a month you're happy on that titrate, then whack it in.
Well, that's the thing. All of this is looking at kind of reducing the risk of therapeutic inertia, ultimately, isn't it? And that kind of very kind of early, frequent reviewing of patients, but also then looking beyond just glucose control and the wider benefits of all these agents.
And as Patrick alluded to, for blood pressure, I've been doing that for a couple of years, actually, initial dual therapy, not for everyone, but for my higher risk patients. Again, the same sort of issues, we talked about with titration and side effects, but it does what it says in the tin. It gets their blood pressure down to target very quickly. Yeah.
And also, the cost, what's the cost of a GP appointment?
Yeah.
We've got to factor some of these things in. That the people who commission services from GP, it's all there's no charge for it, but there is if you're trying to, the good old opportunity cost. If I'm having endless appointments when I'm titrating people's doses and treatments, I can't do something else.
I think perhaps maybe some top line comments on the other SGLT2 trials, SGLT2 inhibitor trials. I know, we've planned to talk about so much today, and obviously we're probably just going to be skimming the surface. I mean, there's Emperor reduced, so the use of empagliflozin in patients with HFrEF. And that was in diabetes and non-diabetes. Yeah. So again, impressive results there as well. So that story about, the role of SGLT2 inhibitors in patients with heart failure and reducing the risk of heart failure admissions it continues to be strong. And now the patients who would benefit from this goes beyond diabetes. So thoughts on how far away are we from, the cardiologist really taking on SGLT2 inhibitors in patients without diabetes?
Well, I'd love to come in here. I think I'm actually looking forward to the cardiologist, because the one thing the cardiologists do compared to the endocrinologists, take no offense here, Omar, is they just get on with it. They don't discuss and fact. So I honestly, I think that will, if we look back, if we pause this moment and come back in 3 years' time, we'll be seeing a huge amounts of initiation, particularly by cardiologists, because they're I have to be a bit careful what I say. I mean, but they just get on with things. Whether they are not thinking necessarily is another issue, but they certainly get on with it, and they've got a track record of doing that across the board with newer agents.
But remember, Patrick, we've got to get the basics right for heart failure as well, don't we? And again, don't get me wrong. I mean, DAPA-HF, Emperor reduced, fantastic results. Numbers needed to treat in the 20s, as we discussed. But we still, don't we, sadly, in primary care, I'll put my hands up here, that a lot of patients floundering on suboptimal doses of ACE inhibitors or ARBs, or not even on these drugs, or beta blockers, spironolactone, diuretics. Of course, no outcome data with diuretics, but just for symptomatic relief. So I think there's still a lot of education required, isn't there, to get the basics right. That, I look at SGLT2s as the icing on the cake, if you like, alongside things like Entresto as well, sacubitril valsartan. Or do you think I'm being unfair?
Not at all. We know that we're notoriously bad at even identifying these patients, diagnosing these patients in primary care as well. I'm not bashing primary care at all. I mean, we've kind of highlighted what a challenge it is, but we know that the prevalence of heart failure isn't the true prevalence. We've got those missing thousands of patients ultimately.
Contrary to what you might think, Patrick, is I don't mind if the cardiologists use SGLT2 inhibitors, as long as they do it safely and knowingly, about especially those patients who have type 2 diabetes. So, I mean, type 1, obviously that's a separate section, but especially in that group, as long as you know the risk.
Emma, on that note, what's your thought on the safety profile? Because it actually does appear now from DAPA-HF and Emperor reduced, the safety profile appears better almost in people without type 2 diabetes.
That's the paradox, isn't it? That's the interesting thing. It's actually safe in those group.
Yeah, because we were worried about the cardiologists going all gung-ho. But actually, when you look at the subgroups and the side effect profiles in both DAPA-HF and Emperor reduced, very reassuring risk-benefit ratio, isn't it? In those, again, without type 2 diabetes.
And there's been talk, on initiation, anyone, if is doing an HbA1c at initiation, even if they don't have diabetes, so you need to know where they are, because there's interesting data from DAPA heart failure that was also presented this year that showed that in those who are at risk of diabetes, type 2 diabetes, potentially, if they had heart failure and pre-diabetes, as they call it, you could prevent the progression to type 2 diabetes in that group. So again, I think that's a reasonable suggestion. I think that's something we might see. But it's safe, relatively safer in those without diabetes than with. So as I said, in those with diabetes, that's where I would be a bit wary. As long as they were aware of it and there's some systems in place, I'd be happy. And that's what I'd say.
Can I move on to DAPA-CKD?
Go for it, yes.
Because I mean, in a sense, there's a similar story going on there, because that was, I thought, for me, this is the standout study of 2021. And this is, and the reason for me it was there is we got, it worked. So we already knew it worked in diabetic kidney disease for patients who had type 2 diabetes or people who were living with type 2 diabetes. But this works, just as we talked about with heart failure, this works in people who don't have diabetes, and to exactly the same degree. And whilst you can't say so there's an outcome which statistically you can't say, but it has to be said. I think I might still say it to my patients, is that it actually reduced overall mortality. So in that study, so and just thinking about the pill burden, because we talked about heart failure, we talked about, I mean, how many drugs are we meant to give for heart failure? And now there's 5 agents we could give to them, but if you've got a drug that does several different things in once, without you coming in with your William Osler quotation, Kevin, at this point. But this is a drug which lowers glucose, which is what it was originally developed for. It now protects kidneys. It protects hearts. If you've got a damaged heart, damaged kidney, these are perfect agents to give, with a caveat that you need to be careful with patients who are at risk of hypoglycemia if they've got type 2 diabetes, particularly if they've got type 1 diabetes. But so that's for a different conversation, or frailer patients, but which often obviously is a challenge, because those people potentially would benefit, but are most likely to get the side effects. But yeah, that was the standout for me, for the fact it worked in people with and without type 2 diabetes.
Patrick, you were also quite excited about Fidelio, weren't you, when we were talking about this earlier on?
I think Kevin was too.
And Kevin.
Oh, well, I think Kevin's even more excited about it than me.
Sorry, Kevin.
But yeah, so over to you, Kevin. You tell us more about Fidelio.
Well, by no means any expert, but it just shows, last year, as in 2019, I felt was very much the year of the heart. 2020, I think, was very much the year of the kidney. From what you said, DAPA-CKD. Yes, we had Credence, at the tail end of 2019, but as well as Credence, DAPA-CKD, we also had this Fidelio trial as well, a new product, not yet licensed. So there's very little awareness, called finerenone, which is a non-steroidal mineralocorticoid antagonist. So very interesting. And again, this showed a significant reduction in the progression of DKD, diabetic kidney disease. So in contrast to DAPA-CKD, this was explored in a population of people living with type 2 diabetes with CKD, so diabetic kidney disease. So quite a specific population there. So really, really interesting. And again, whilst it's great to get excited about it now, my heart sort of sinks a wee bit, in a year or two or sooner, when it gets its license, it's going to further complicate that landscape of diabetic kidney disease. Amrit already mentioned, didn't he, at the beginning, about identifying patients, actually how many patients are going to benefit from this drug. So suddenly we have canagliflozin or dapagliflozin, and now we have finerenone, and actually my New England Journal of Medicine table of contents was emailed to me a couple of weeks ago with another couple of experimental molecules for reducing the progression of DKD. So it's going to get really and surely it's a law of diminishing returns at some point as well, isn't it?
And it gets complex when you think about the person who has cardio-renal syndrome, or who has cardio disease, heart failure, CKD, DKD, and diabetes, and kind of which evidence do you go by? What do you put in? Which hierarchy of kind of additions do you put in? Where does finerenone sit? Where does I mean, SGLT2 is probably sit in the beginning of most, but which SGLT2 and when? So there's a lot of questions to ask.
Get the basics right as well for DKD, don't we? Like heart failure, the ACE inhibition, optimizing the cardiovascular risk factors, not too tight on the glycemic control, all stuff we're familiar. So again, no, don't get me wrong. Again, very exciting study. And there's a sister study, the Figaro study, due in 2021, later this year, as well. So that's going to add to that evidence base for finerenone, hopefully. So yeah, very exciting time.
Amar, as if we hadn't spoken enough about SGLT2 inhibitors, any comments on the SCORED and SOLOIST trials for sotagliflozin?
So interesting. Sotagliflozin's had an interesting history, isn't it? I mean, it was product aimed at kind of people with type 1 diabetes initially, and Sanofi and Lexicon got together to do this. And then things didn't kind of work out as planned, because as we know, SGLT2 inhibitors have their risks in type 1 diabetes. It's licensed in the UK though, isn't it, for type 1, but it's not marketed. But they had their cardiovascular outcome trial that was unfortunately affected by the current pandemic, and so they had to revise the kind of criteria and adjust it accordingly. So because of COVID times, they had to cut it short and look at it from that point of view. But they found some really interesting stuff. I mean, there's a lot of things there. The problem you have with any of the data they found, so they found, potentially in HFpEF, there was some benefit. We've had potential benefit in stroke, which is the first SGLT2 inhibitor to show some potential benefit in reducing number of people who had strokes in the trial. We had some obvious benefits in CKD in kidney disease. So again, we had these data, but it's all been a bit tempered by the fact that it was cut short, and it's really frustrating because if it had showed all those things, you'd be right back in there and say, sotagliflozin, it does all these things. Perhaps it would rival the other SGLT2 inhibitors. At this point, we can't be sure what they've shown. And I think that's the frustration I had. I don't know if anyone else had any thoughts on it.
Sanofi, I know, have stepped back from that relationship, don't we? Do you think the data is compelling enough that someone else will step back in? Or?
The problem is you might have to redo a cardiovascular outcome trial again. But these aren't cheap. No, what's it? How many hundreds of millions it may cost? So again, I don't know if the benefit is there when you've got such good data for the other 3 or 4 now. I don't know if it's worth that. But then again, I don't know. It depends where it's in other parts of the world. If it's being used, maybe that's somewhere else it could be used. But yeah.
I agree. I saw those 2 studies as well as a tantalizing glimpse of what's yet to come. You mentioned HFpEF. If I had my proper geek hat on, I think it was actually HFmrEF to be specific. Yeah. Another hopeless terminology that we're trying to get our heads on. Heart failure with a mid-range ejection fraction or middling ejection. And then also benefits, as you said, in CKD with normal albuminuria or certainly microalbuminuria. Sorry, I should say. So really tantalizing glance of the future of what studies later in 2021 and beyond might show. But yeah, as you said, disappointing. Just it was cut short. So. Yeah,
it's the gift that keeps giving, as they say.
Yeah.
SGLT2 inhibitors, absolutely. To be continued, no doubt. I think I wanted to talk a little bit about some of the new products that have come out onto the market, actually. I think the product that I've had an opportunity to use a little bit of is oral semaglutide, which was something that we'd heard about for quite a while. We were all getting really excited about. Because we know that one of the challenges of using GLP-1 therapy in the community is the injectable element of it. Not only from the clinician's perspective, but also from the patient's acceptability of that mode of administration. So oral semaglutide was launched just a few months ago. I think it was launched in the States a few months earlier, wasn't it? And it's been great to have that as an additional option. And I think the conversations that I've had with patients have been a little bit challenging, actually, to actually realize where it's best suited to be used. And I think that's reflected a little bit with some of the local formularies as well, who are scratching their heads a little bit. Where is this an oral anti-diabetic agent? Does this fit into the GLP-1 group where you think about all the other injectables? But yeah, some great positive feedback from some of our patients. So daily oral GLP-1 agonist. Guys, have you had much experience with it?
I'll come in here. I mean, I think it's early days. I think we just need to keep an eye on this one because, I really have very small numbers, but my results are mixed. And I think I was always slightly alarmed. I had one patient who said, oh, no side effects at all, no side effects at all. I've just got his HbA1c. And this is someone who previously had responded quite well, actually many moons ago on liraglutide and had some bariatric surgery and his HbA1c crept up again. And he was keen not to go back on an injectable, was very happy with the oral. And we're talking N of 1 here. So that needs to be the caveat. But his one has come back actually he hasn't changed. And I'm just wondering, I've now called him in because I want to see is he taking it the right way? I've spent a lot of time telling him to have it with, with a sip of water first thing in the morning before half an hour before he has anything else to eat. But I wonder if he's following my instructions to the letter. But in the same breath, I've got others who have responded exactly as you would expect them to do in the trial, and they've done well. They've got some GI side effects perhaps, but they're now tolerating it better. So I think I personally, and again, this is probably looking to this year, 2021, I'm looking forward to the observational data to come out of the States. We've had this for a long period of time to actually see how easy it works at scale. And I would agree with you. It's for someone who's a real advocate of GLP-1, it's good to have it as an option. Personally, I quite like the dance we have with patients actually trying to get them to inject themselves. I love the appointments. I start these in my 10-minute appointments because they're too much fun to give to the nurses. Sorry if there's any nurses watching. I give them the drag on of insulin and all the information they have to give to people. But with a GLP-1, I love giving that first injection, or watching patients give the first injection themselves and saying, "Is that it?" I love it. But
glory hunter, isn't he?
Yeah, so we'll see. I mean, I don't know, Kevin. I mean, you were involved, I think, in the launch. So I've been listening to you telling me how to prescribe it. So and how to counsel patients. What's your experience been?
I've got about four or five patients on it now, actually, and I've got to say, quite positive benefits. All of them, in fact. Well, a couple of them actually we had to maybe tail back on things because it was almost working too well. That profound impact on the appetite was actually they were struggling with, and associated significant weight loss. But I've got to say, it does what it says on the tin in terms of the glucose lowering and the weight. But as Patrick and I think Amrit alluded to, it's not for everybody, is it? I think that was quite clear from the outset. It's not the panacea perhaps we were all getting excited about a couple of years ago to type 2 diabetes. Yeah, I think Amrit used that phrase, didn't he? It's another tool in the toolbox. Is that
absolutely. And I think it still comes back to the individualizing the treatment for everyone.
Yes.
And for some patients, the injectable will actually be more suitable in every kind of aspect. One thing I just wanted to ask you, Amma, perhaps your thoughts about, the cardiovascular data lacking to some extent for oral semaglutide. Is that something that we really need to be paying attention to, or is that something that you pay attention to?
It's interesting, isn't it? I mean, we're such proponents of data and evidence-based care that we should say yes, it means it's a lot. But in this setting, it was an interesting one because I had to kind of get it authorized on our formulary and that side of things. And I mean, the data, okay, it's a non-inferiority trial. It showed it was non-inferior in terms of outcomes. There's a superiority trial going on SOL-D, isn't it? That's coming out in a couple of years, maybe. But if you look at this, okay, we never look at secondary outcomes analysis, but the cardiovascular death and mortality, 50% reduction in that is amazing. It's ridiculous, actually.
Small numbers, though, isn't it? Very small
numbers, yeah, exactly.
It's not just small numbers, but a very short trial. And I think that's for I mean, these GLP-1 agents seem to modify the atherosclerotic process. So, they're often driven. I mean, you can look at the individual trials and they have slightly different outcomes, but overall, it seems to drive stroke downwards. And so that feels an important outcome. I mean,
absolutely.
Stroke, it's a fear of us all, but certainly for people living with diabetes.
Going back to how we started off our conversation tonight, very much the path has been set now. Atherosclerotic cardiovascular disease, very much the GLP-1s, but your pump failures, your filtering, very much the SGLT2s, the heart failure, the CKD, isn't it? I think that recent evidence has really reinforced that dichotomy now, isn't it, of using these agents. So,
and as you mentioned, I mean, oral semi I see as a patient choice. We've got an oral option. I said, it's probably not as when we first heard about it in ADA, I think a few years ago, the trials, we were like, wow, this is going to change the world. But I think we've realized actually it's maybe not so exaggerated, but it's certainly things that it may help us with.
Absolutely.
I think it's another tool, as you said. I think that's important.
Especially during this pandemic, when I appreciate, Patrick, you love the dancing, as you said, with the GLP-1 patients, but a lot of our colleagues who are perhaps not so confident starting GLP-1s, this is a tablet they may well start, during the pandemic.
It's difficult to dance, as you say, if socially distanced. So
I was going to have a disclaimer there, just to say Patrick is not actually dancing with his patients. He's initiating GLP-1.
I've seen Patrick dance, though.
By himself afterwards, perhaps, possibly. Any other new medications that you guys have initiated this year that you want to give your thoughts
Patrick,
on?
that must be your...
I'll do this as a caveat. In a sense, I was reliably told by my regional manager for AstraZeneca that I was the highest prescriber of SGLT2 inhibitors in the world. So I think I'm a bit of an early adopter. I think it was only for 1 month because I hand wrote a few scripts. But there's an interesting molecule called bempedoic acid. So this works a couple of steps up the same pathway as the statins do, but it doesn't impact on muscle in the same theoretical way that statins can do. And as an agent, it can be either used with people on statins who've not achieved their lipid-lowering targets, but probably most interestingly, and certainly this is where I've been using it, in patients who are at high risk, who can't tolerate statins. And believe you me, I'm a statin lover. They've had 4 statins and I've given them, tiny doses of pravastatin or fluvastatin even sometimes just to get them to take it. And then they say, I've got muscle side effects or whatever. And I use that with ezetimibe. There's a branded product called Nusendi. I think I'm the only person in the UK as we speak who's prescribed that. But so just, so I'm not suggesting this is a mainstream medication. But the interesting, we had some published data on it earlier on. In combination with ezetimibe, you're looking at about a 40% reduction, which is similar to a Atorva 20. So I think that's clinically meaningful. Going back to something I said earlier on, all we have at the moment is surrogates. So this stuff lowers your cholesterol, your LDL. Does it reduce heart attacks and strokes? That's the most important thing. At the moment, we don't know, but the good thing is there is an ongoing clinical trial. So certainly in 18 months' time, we'll be able to answer that question. But for those patients who can't tolerate statins and who don't qualify for PCSK9 inhibitors, what else are we meant to do? So, NICE are looking at this. I think
remind me what NICE say.
I think we'll have to see what NICE says. But remember, when NICE do come up with their verdict, that's guidelines. It is to guide clinicians. What you do is between you and your patient based on everything you've got, not just slavishly follow the guidelines.
Yeah, SMC have actually knocked it back initially, bempedoic acid, on cost effectiveness. But I think they're going to revisit that. There's no doubt this will drive a price change. But again, it's just nice to have another option, because even ezetimibe, Patrick, that's just working on surrogates as well. Up till recently was really working on surrogates. I know we had that Improve It study, but the number needed to treat was well over 100, wasn't it? And a small group of people. So even the ezetimibe, it's not had really compelling data. So really, aside from statins, we're still lacking. Well, I suppose before we get onto the PCSK9 inhibitors, but in terms of oral medications, we're really lacking, apart from statins, aren't we, in lipid-lowering options?
And we do need extra quivers for our bow. I mean, we do, because we know, what is the number of people who stop taking statins within 2 years? We're approaching 50%, in terms of taking it on a regular basis. So we do need something. And whilst it's almost a conversation in its own piece, the whole side effects with statins, but which I'm again, looking back, we've got a little bit of data suggesting that probably 90% of the people who are complaining about side effects with statins, perhaps it is the nocebo effect. But it doesn't matter. If they're not going to take it, they're not going to take it. Yeah. It goes back to what that Sam Saidu quote is. If the patients don't take it, it ain't going to work. So we do need, a plan B.
And that moves us on to this newer medications that may be coming through, isn't it? Inclisiran, or inclisiran, as Kevin says. Again, another one where we do separating what we say. Yeah. But that's a twice a year injection, isn't it? It works on the RNA side of things, so we're hearing this term more and more now. But that's something that hopefully in the next year might come through, and the data shows some quite good cholesterol lowering reduction. But again, no primary outcomes, I think.
Amar, I think it's going to come even quicker. The EMA gave it its approval in December 2020. So that's 50 days between that and it being able to be marketed. So it's coming much quicker. And I think the NHS have struck up a deal with Novartis, who've developed it. And I suppose, the reason, just to throw back in the bempedoic acid and try to defend myself as the first prescriber in the UK of the combination product, down the line, that's going to be, again, I'm going back to being the old man in the group, 18 years older than you, Amar. So I can see this through the long scope, really, and these branded products will be generic in due course, and these small molecules will be cheap. But and again, inclisiran, I think it's twice a day, so yeah, it's going to be pricey initially, but potentially that's going to be a lot cheaper down the line if you only got 2 injections a day. Oh, sorry, a year, 2 injections.
Yeah.
Good stuff, boys. I'm conscious of time here. We could chat all evening as usual, but I thought perhaps a topical way to round things off is, of course, the elephant in the room. It's great to have all this exciting option, guidelines, research, license changes, but we're under colossal pressure, aren't we, at the moment in primary and secondary care with COVID. So perhaps a discussion of some of the pertinent COVID-related issues. And I know, Amrit, this is something you've been very, very passionate about locally and on a wider basis. What's grabbed your attention over the last? Well, there's so much, isn't it, that's grabbed our attention over the last 6 months in terms of the challenges we're facing with COVID.
Yeah, absolutely, Kevin. I suppose, like the pandemic itself, which has been a journey for everyone, and unfortunately has had a massive impact for most people, actually, if not everyone. A similar thing could be said about the story of diabetes and COVID.
Yes.
Because it was very clear after the first wave in the UK that there was an association that had developed really between diabetes and COVID mortality in particular. And in May, we had the first real data from NHS England that showed that, by that stage, 1/3 of all deaths related to COVID-19 were associated with the diagnosis of diabetes. And also, there's clear data showing that those people who were admitted to hospital with diabetes, type 2 diabetes, were twice as likely to die from it. So very striking, sort of stark data. And that had, I suppose, for me, locally and also regionally, it'll be really interesting to hear your guys' thoughts on things, but that had a massive impact on us. How we then looked at this cohort of patients who are clearly high risk of complications of COVID-19 and how we managed them in a remote setting. And we saw very early on, I think PCDS came out with some very good guidance, essentially, on how to undertake a remote consultation, but still not the easiest of things at all. And I think we all had to start developing new skills. Our patients also had to start developing some different skills as well in how to interact in that situation. But one thing that came out of it for us was the importance of risk stratification. So identifying patients, and again, from that data, we saw patients with particularly high HbA1cs, particularly high BMIs, were at even greater risk of the COVID-19 complications. So that's something that we've certainly started to adopt locally, and I think that's obviously now become national recommendation in terms of how to review your cohort of patients with type 2 diabetes and type 1 diabetes by risk stratifying based on things such as HbA1c and BMI. But it's been a challenge, and I'd be interested to hear how you guys have managed your patients. Again, we've got a nice split here. Well, it's 3 against 1, but primary care versus secondary care. Amar, it'd be interesting to go to you, actually, how you guys dealt with your patients over this time.
Yeah, it's been an interesting one. I mean, I guess we've a lot of the time we've had to cancel a lot of clinics. We've left it to you guys in a way to support part of that, because we've had to cancel clinics to manage the inpatients. But again, that's provided a slightly different challenge in terms of once you've been admitted with coronavirus and have diabetes, what do we do then, and how do we support you there? In terms of risk stratification, I've in the hospital, what we've done is we've had a bit more input into what's happening on the wards in people with diabetes. So regardless of whether they're in with COVID or not, our diabetes nurses are looking at them and reviewing and seeing what needs to be done, and in a hub where they look at the looking at blood sugars and see what's going on to try and optimize care. In terms of trying to stratify patients generally, I do work a bit with primary care as well in CCG. So we have done some work on your, as you mentioned, risk stratification. But what's interesting is that there's a slight difference in primary and secondary care in terms of what we can do or what we're focusing on a bit. So in a way, I'd say it's really what you guys are doing, which is kind of helping a lot in that sense of things. And we're dealing with kind of a few of the things in between. So the onus is a bit, unfortunately, on your side.
Yeah, we were discussing this earlier, actually, off air, we might say, about the risk factors. Patrick, I know we were talking about, obviously, age has come out as a very kind of strong risk factor, ethnicity as well, and some of the, potentially some of the social factors that are linked to that as well. What are your thoughts in terms of, the practicalities of actually doing something with those risk factors?
I think it's difficult. I mean, I suppose, I mean, without getting too serious, because it's meant to be quite light, but I think we're at an important time, actually, as a society. I think, I come from the viewpoint that everybody's life is worth the same. We're all born at least of equal value. But we're seeing, people dying not at the same rates. People from more deprived communities, be they of color or the BAME community. We're seeing that particularly in London. Often it looks to be mainly, although they can't fully through the data say it is this, but it from my reading on it is that it looks a lot to do with multi-generational households and to do with occupation. But I mean, I think and the whole viral load theories, in terms of healthcare professionals, why they've been hit harder. Particularly in London, you've got people working in public transport, being hit hard. So I think this is important stuff. It's not just, it's where medicine and science comes along with society and how we structure it. So it's I don't want to bang on too much, but I think that we're going to have to learn about how to manage this and
it's the inverse care law, isn't it, Patrick? It sadly originally coined 30 years ago, and now more so than ever, arguably, very, very apparent. I mean, there's no doubt this pandemic has widened pre-existing health inequalities, and it's a really tragic situation with no easy solution. We talk passionately about the science today, the therapeutic options, etc., but there's little, sadly, we can do about the social determinants of health, the unemployment, the poor housing, etc. Is there at the moment? So it's a very. I mean, I go to Amrit's question. I found the risk stratification really difficult, Amrit. On one hand, yes, I had patients with very high HbA1cs, but equally, I had patients with well-controlled HbA1cs, but with significant comorbidities, or who are significantly overweight, or morbidly obese. But so I found it really difficult. My practice nurses at my team, we all found it really difficult. How do we fairly, equitably manage people's chronic disease, not just diabetes, all the disease areas?
I suppose that's a really important point, that it's not just diabetes. All the chronic diseases obviously are being affected in that way. But I suppose it's an important point that we need to consider. Maybe where do we start? Do we have some focus point, especially now? Here we are, early 2021. In primary care, we've been asked to pull back on certain elements of our service provision. So yeah, I mean, I think it's quite easy for a primary care clinician to feel a little bit lost in amongst all of this, and actually requiring something to focus on. Patrick, I can tell you're itching to come in here.
I thought the data, the Villaggi data, from NHS England was really important, but it's worth, it's detailed stuff. But remember, if they'd not had, we had this, if they didn't have smoking status recorded, that was higher risk than if they smoked or if they didn't smoke. So I think what what it was for me, some of this data was saying, and this probably applies, you know, HbA1c to me is often someone who's not engaged with their diabetes. They're not taking any medication. That's, you know, as a GPSI with a special interest, you know, I'm forever being given these patients with HbA1cs above 100, and apparently they're on 4 or 5 different drugs, but they're not taking any actually once you boil it down, certainly not on a regular basis. So I think you know, it comes back to those health inequalities and actually, you know, how we restratify is you know, because we're often driven by data, but it's the absence of data, which is often the highest risk people. I don't know what the solution is there, because it might not be someone like me going to them. I don't know what the solution is, but maybe, I mean, in England, we've got primary care networks and we're trying to work at a population level, and hopefully we'll come up with solutions to this. But it is challenging. It is challenging because, you know, let's say, you know, because I could make an argument for using GLP-1 receptor analogs because they reduce weight. They're very effective glucose-lowering agents. These, you know, based on the data we've had, they should be really good drugs. But of course, you know, they cause side effects. You need to be very motivated to take them. So they're not easy to take. They're either an injectable or, as we've discussed already, require, you know, good compliance to a particular regime. So I think it is a challenge how we really get our grips at the people at highest risk.
I just want to end that really with the kind of summary. I think what the data has shown is that COVID-19 has probably magnified the discrepancies in care from a socioeconomic, from a health inequality perspective. And I think how we address that forward, because this data is still there. We've seen it in other medical conditions pre-COVID as well. So this is just magnified. And I think this is the thing that what we do next is very important.
Brilliant. Thanks for that. I think, I suppose, obviously quite a poignant kind of point to end on, but obviously we're still very much in the midst of the pandemic. I know Patrick was yesterday was vaccinating. So there is that glimmer of hope that, you know, over the coming weeks and months, we'll be flattening that curve and getting back towards gaining some control on the situation, and all the you know, the exciting talk on data and whatnot that we've kind of spent an hour talking about today. Hopefully we can start, you know, implementing and putting into practice. But I think it's been great to have a chat. You've hopefully got a bit of a flavor of what our chats are like, and you know, you can tell it's quite geeky at times, but with a little bit of lightheartedness as well. And I'm sure you'll get to know us a little bit better over the course of our, you know, following podcasts. And in fact, on that note, we've got another podcast which will be following this shortly. And that's really to look at the highlights, what we're going to be looking forward to actually in 2021. So I hope you can join us for that as well. And these will be available on YouTube as videos, but on other platforms as well. And we'll be giving you more information on that in due course. Now, I know Kevin's itching to tell you about our Twitter presence as well. So me being a complete novice at Twitter, I think I've got a Twitter profile, but I'm not very active at all. So I'm going to hand over to Kevin to give you some more details about that.
Well, I really should ask Patrick and Abba. They're the Twitter pros here. But please do follow us all on Twitter. We each tweet hot topics or other information of relevance to that cardio-renal-metabolic landscape that we've been discussing over the last 1 hour. So my Twitter handle is @Dr. Kevin Fernando. So please do follow me. Patrick?
Very similar to yours. Mine is @Dr. Patrick Holmes. That's me.
And mine is @Amarput. So too long a name, made it short.
And I made a point of memorizing mine as well. I've just realized what my Twitter handle is. It's @Dr_Amrit-Lambert.
Good stuff. So yeah, thanks again everyone for listening. Boys, thanks for this evening. That was fun. And here's to this is the first of hopefully many more GoggleDocs webcasts and podcasts. Thanks very much for joining us, everyone.
Brilliant. See you later, everyone. Bye.
Bye. Bye.
Thank you. Bye-bye.